Welcome to everybody who's joining us today. I'm just going to give a couple of minutes because I'm conscious that Zoom links can take a little bit of a while to get clicked through and up and running. So we will start in just a couple of minutes. Welcome everybody to the March VAMHN webinar. Huge thank you to our speaker, Dr. Adeline Moussion Esteve, who's going to be speaking to us about sexual violence in the context of domestic abuse. And thank you very much everybody who is joining us today. Just a little bit of housekeeping before I pass over to our speaker. Just to reassure you that we are recording the webinar today, and you will receive the link to the recording, so you will be able to watch this back at a later date. We will also be sharing a copy of Adeline's slides that they will come out with the recording. They'll be with you in the next few days. So you will receive the slides and you will receive the recording. They'll also be posted to our website. I can see lots of familiar names in the attendee list, which is lovely. Welcome back to those of you who have been with us before. If you've not been to one of our events previously, a warm welcome to you as well. And I'll just quickly go through how we tend to run the events. You have a chat box and we also have a Q&A box. We encourage you please to use the chat to say hello, introduce yourself, share any links and resources that you think other members of the group might benefit from accessing. And then if you could use the Q&A box please, and you might, if that isn't immediately obvious to you where it is, if you click on the More button with the three dots towards the bottom of your screen, you should see an option for the Q&A box. If you could use that box, please, for any questions that you would like to put to Adeline, that makes it a lot easier for me to be able to keep track of questions as they're coming in rather than scanning the chat. Adeline will be speaking for around 20 to 25 minutes, and then we'll have time for around 15 to 20 minutes of questions. You're welcome to put your questions through at any time during the talk, but we'll be taking those questions at the end. Just to also highlight that, as is hopefully apparent from the title of the talk today, this talk does have sensitive content material on sexual violence. Just really would encourage you to take care of yourself during today's talk. If you need to step away from the talk at any time, you're very welcome to do that. And if you want to reach out to the team afterwards, you're welcome to do that also. We do also have a list of good help and signposting resources on the VAMHN website, and Deezer, if you could put a link in the chat to those help resources, that would be really useful just in case anybody wants to access those during or after today's talk. That is all the housekeeping that I want to do, so I won't hold our speaker up any further. Adeline, thank you so much for being with us today. Really looking forward to hearing your presentation. Thank you.
Thank you very much, Sian, and hello everyone. I'm really glad to be able to present my work to you today. What I will present today was done as part of my doctoral research, which explored ways of framing the experience of domestic abuse beyond PTSD and trauma. And today I'm going to more specifically talk about the experience of sexual violence within domestic abuse and try to offer an alternative conceptualization to the models of incapacitated avoidance, among which is PTSD and trauma. I'm going to really rapidly introduce myself. I'm an anthropologist by training. I'm also a feminist researcher. I did my PhD at Birkbeck as a member of the Sexual Harms and Medical Encounters Project, the SHAME project. I am currently a postdoc at Birkbeck, this time looking at child sexual abuse and recovery experiences in the Recovery Histories project. I published some papers from my PhD. Two are in French, as you can see, and one in English. So one on domestic abuse and experiences of fear, another one on the French public policy figure of the victim of domestic abuse and how it erases mothers' experiences, and another one on survivors of sexual violence, intentional practices of forgetting. And all of these papers are try to be in critical dialogue with public policy norms from the French context and with the trauma PTSD register. Briefly about my PhD research and my methods. I conducted fieldwork in 3 sites in France, in the red area that you see near Paris, which is a low-income area called the Seine-Saint-Denis. So I observed expert discourses on sexual violence, domestic violence, and trauma in training and in conferences for professionals. I also observed professionals in an organization for women victims of violence that I call For Women, which is a pseudonym. And within this organization, I followed 7 women, which I followed in and out that organization and in their everyday lives. I mostly relied on participatory observation, and I recorded interviews, 5 repeated unstructured interviews with these 7 women, and 1 semi-directed interview with each member of the staff when possible. A quick note on terminology. Even though I know that in the UK context favors the term survivors, I'm going to be using the term victim in this talk because that's the category that circulates in France. And final point on this project, the basic finding and what led me to do this work was that even though these 7 women knew of PTSD and of trauma, because they had been taught to frame their experiences in this way by practitioners at For Women, they did not use the term trauma, nor PTSD, nor the logic of trauma with me when they were describing their lives and their experiences. So what I tried to do is to document their experience and to conceptualize the harms of domestic abuse beyond the register of trauma. These 7 women that I closely followed were all French, and they were all living in economically precarious situations. Their positionalities rendered them vulnerable to sexism and racism for the most part. They were aged between their late 30s to their late 50s. 5 of them were Muslim, and 5 had children while experiencing domestic violence. And among these 5 women, 3 were still currently parenting their children. During my fieldwork, I observed consultations at For Women, and I also accompanied patients out of For Women wherever the staff wanted me to accompany them. So I went to the forensic unit, the police station, the hospitals, public services. And with these 7 women, I tried to shadow them on their every ordinary life. So for instance, I accompanied them in different activities like shopping, going for walks, being with their children, eating at restaurants and in coffees, because I used my research money for those purposes, but also going to appointments with their lawyers or at the police when this was necessary. So I spent time with them on a daily basis to try to gain access to their ordinary life. They knew of my object of study because they signed a consent form which explained my project. But my main method of data production was to not ask about violence and to not bring the topic of violence myself into our conversation. Instead, I followed what I call spontaneous foci of attention to document the concern which occupied them in the aftermath of violence. I'm going to briefly describe what I mean by trauma and models of incapacitated avoidance. In those expert and professional contexts, there were 2 ways in which victims of sexual violence could be defined as unable to protect themselves from abuse. either as an acute reaction with the terms of terror, dissociation, freezing, or sidération in French, or as a chronic incapacitation, this time with terms such as PTSD, emprise, or insecure attachment. According to expert discourses, at the time of the traumatic violence, immediate avoidance could be impeded by dissociation or freezing, which represent acute forms of paralysis. For instance, one practitioner at 4Women explained during a support group that, quote, stress has hormonal effects, it freezes you. Neurological and hormonal processes were said to prevent victims from consciously avoiding the violence. Traumatic events were said to produce a specific form of stress, launching a survival mechanism in the brain, organized around avoiding vital risks. Another example, and that's the first quote you have on the left. During a training session at the Feminist Collective Against Rape, we were taught the following scenario. Imagine I'm walking in the forest. I have the basic equipment to deal with danger. There was a tornado yesterday. My eyes register that it's abnormal that the trees are moving, the noise too. All of this ignited the brain's amygdala. My alert system kicks in. There is a production of stress hormones, cortisol, increased blood sugar, and adrenaline. My heart beats faster. I'm programmed to fight or flight. I fled. My hippocampus will register the event and remind me to not go into the forest during a storm. Contrary to this normal flight option, the trainer stated that a child enduring incestuous sexual violence experienced freezing. So that's the second quote you have on the slide. Imagine I'm 6 years old. Daddy comes into my bed, undresses me. Adrenaline is toxic for the heart. It is possible to have a cardiac arrest from terror, and cortisol burns the cerebral neurons. As we are living organisms supposed to live a long time, we switch off when facing a danger. Morphine-like and ketamine-like hormones are produced. I can't feel anything. The 6-year-old girl with her dad has no reactivity. She's there, like a deer in the headlights. It freezes. So in these scenarios, a child and a deer share freeze reactions when facing a danger to their organism's survival. In addition to these acute paralysis responses, experts also warned of chronic forms of incapacitation. Several models circulated, among which were the development of, quote, addictions to cortisol and adrenaline, searches for occasions to dissociate. Victims were also said to develop traumatic personalities. Experts highlighted forms of chronicized stress. At 4Women, professionals were taught by experts during a staff counseling session the following knowledge that you have on the slide. Domestic violence has several traumatic impacts, a stress overload, which makes the subject feel threatened. From this point on, a state of acute stress or even post-traumatic stress develops, which is a form of chronicization of acute stress. The reaction is perpetuated in the repeated shocks of domestic violence. According to these discourses, victims' behaviors, repeated patterns of incapacitated avoidance, and these claims were often evidenced by biological processes. As neither the context nor the repetition affected victims' responses to violence. And what I want to do now is to contrast these discourses by showing some of their blind spots, namely that in contexts where violence is repeated and anticipated, victims can organize and create forms of agency through not resisting to some acts of sexual violence. I also want to show that not avoiding some acts can be a form of a rational tactic of resistance to be understood in specific context. This form of agency, which the women I worked with identified as detrimental but still necessary, show the limits of framing the consequences of violence merely as a form of incapacitation. And I also want to engage a discussion around the uses of biological elements to prove victims' innocence, because if they manage to challenge victim blaming, they also do not fully depict the complexities of resisting within repeated abuse. So expert discourses affirmed that traumatized victims were unable to avoid future events of violence, either due to acute or chronicized patterns of incapacitated avoidance. In contrast, women's experiences of sexual violence within domestic abuse highlight another picture of avoidance and resistance. The women I worked with depicted ways of resisting abuse without opposing to certain violent acts. And these practices can be interpreted as, if they could be interpreted as an absence of opposition, actually denotes forms of resistance, which is what I'm going to be talking about now. Among the various tactics for handling the threats of domestic sexual violence, saying no was not a preferred option. And women found other ways to negotiate with the constant accessibility to their bodies. They recalled saying no sometimes, although they were not always listened to. Sonia described having to sometimes beg her husband not to retaliate if she said no to sexual intercourse. Armel and Sonia recalled that saying no represented the risk of physical brutality, economic deprivation, or harassment in the following days. And contrary to what their keen friends or some practitioners told them, saying no was not necessarily beneficial. As an example, after confiding in her GP that her husband was forcing her to have sex, Armel's GP shook her hand by the end of the consultation and said, "You make me proud, will you? You tell him no, don't disappoint me." This injunction made Armel feel misunderstood, ashamed, judged, and powerless. She was aware of the material constraints rendering her no unsafe, and she commented, that's the quote that you have on the slide, "Those who say, just say no, in fact, they don't know what it's like to live with the person on your back to the point where you can't go anywhere but in the house." Sonia, Lorraine, and others described forms of resistance which did not rely on verbalizing their refusal. Some tactics aimed to discourage even the initiative of sexual intercourse without having to interact with their partners or to oppose them physically or verbally. For instance, Kaina slept in their children's room, or Sonia resorted to sleeping with several layers of clothing or in jeans, because these are more difficult to remove than pajamas or safer than sleeping naked. Other tactics focused on controlling the consequences of domestic sexual violence, even when the sexual violence in itself was not avoidable. For instance, women anticipated the risk of forced pregnancies or STDs. Sonia recalled going to her doctor to ask for blood tests regularly because she anticipated that her husband might also be cheating on her, and she didn't want to get sick because of the sexual violence he might later commit. At For Women, practitioners recalled patients asking for contraceptive arm implants when their partners refused to use any contraceptive. As one of them described, one of a patients shares that a pill can be found and an IUD can be touched with fingers, so an arm implant is actually more discreet. Pregnancy was recalled by these participants and is also described in the literature as a period of escalated violence. So controlling unwanted pregnancies handled the consequences of acts when the very avoidance of the acts was not possible. So we can see in the very first practices I described attempts to avoid the act of sexual violence. But also we can see that Sonia, Armel, and others used knowledge about the context of domestic sexual violence, the conjugal room, and the sharing of a bed without clothes being the ideal typical situation. And they also used knowledge about the consequences of sexual violence, STDs, and pregnancies here. What we can see is a broader temporality than the acts of imposed sexual activity was at stake, their future, their health, and their reproductive life, as well as the potential aggravation of their present difficulties. So not resisting some acts of sexual violence could coexist with attempts to mitigate the husband's conjugal reproductive and health control. When these anticipatory tactics did not discourage the acts of sexual exploitation, humiliation, or submission, And when ending the relationship or leaving or saying no or opposing were not possible, Kaina, Armel, and others turned to what I call instrumental endurance. In Armel's view, feigning consent or feigning sexual pleasure gave her some means to control certain elements of the imposed sexual acts, namely the brutality or the length of the coerced sexual intercourse. Feigning pleasure did not avoid enduring what she called a rape, but it enabled her to regulate how long and how her coerced sexual activity would last. She explained, that's the quote that you have on the slide, "With my ex, I didn't feel like it at all, but when I said no, it ended up being a rape, nothing more, nothing less. So you pretend, you moan, you pretend, you moan, you move, he's happy, and then that's it. It goes quickly, and you want it to go quickly, so you do everything to make it go quickly." Her pleasure and consent were feigned in an instrumental way, as these practices were linked causally and temporally to an after, which depended on Armel's submissiveness. The sexual activity that Armel is describing here consists of a penile vaginal penetrative sex. So she used knowledge about male sexuality to anticipate the duration of the acts. She anticipated that it would be over once her husband was happy, so probably after an ejaculation, that she handled by using her body and voice in specific ways. Controlling her husband's sexual pleasure through the uses of her own body reduced the duration of her instrumental endurance, and the whole handling of the situation rested upon her ability to fake pleasure and comply to a sexual script until this end point. Another tactic is that of feigning initiating a sexual act herself so that it is not imposed by force, so as to control some features of the constraint. Anticipating brutality, for instance, Armel described starting some sexual act herself by forcing herself, without her husband having to impose them verbally or physically. Other tactics focus not on avoiding the coerced sexual intercourse in itself, but on avoiding certain acts and choosing the positions that she would knew, for instance, in the case of Julie, that they would be more or less painful. What I call instrumental endurance highlights women's agency within a very constrained context and denotes temporality and concerns which are not limited to a series of acts of sexual violence. Instead, endurance is a means considered with the longer-term plans in view, and avoiding the acts of sexual violence was not the goal of women's practices. Rather, an avoidance of other forms of harms, such as harassment, brutality, or blackmail, dictated women's instrumental endurance. If we look at the literature, and for today I'm just going to mobilize Ivan Stark's coercive control theory, these women bargained with coercive control by enduring some acts of sexual violence. And I don't really have the time to go through it today, but there are similarities between these cases of enduring and feigning pleasure or consent with other feigning practices to negotiate with physical, verbal, and emotional violence within domestic abuse. For instance, for women who are parenting their children, silently enduring forms of physical or verbal abuse was also a means to enable their children to not listen or to not hear what was happening and to create some form of normalcy for their children. So these practices entail specific forms of submissiveness, which I document in the fee paper that you have on the slides. These forms of resistance unfold within a temporality and roles over which some control can be organized against, even in ways that contrast with legal requirements of resistance and expert knowledge on incapacitated avoidance. If we interpret these responses to violence independently from the framework of trauma, PTSD, acute or chronic incapacitated avoidance, we can see how apparent submissiveness can also be a means of resistance within extremely constrained contexts, beyond verbal or physical opposition. We can see how not doing or saying anything does not mean not resisting, consenting, or putting oneself in danger, or seeking out risky situations, which are also discourses which circulate with incapacitated avoidance. In what I have described, the women I worked with progressively knew what to expect in situations of repeated and anticipated violence. They knew what they could safely do and what could lead to retaliation. The practices and the knowledge that they put to work denoted rational attempts at handling violence, although from the vantage point of professional knowledge, they could be interpreted with the knowledge that I documented in the beginning of this talk as incapacitated reactions with biological causes. This framing shows that the instrumental endurance of domestic sexual violence secured some of their interests and offered them some resources for future action. Instrumental endurance shed light on a form of agency within a constrained life setting and with limited structural solutions. This is a context bound and performed through various sets of knowledge and know-how that respond to both interpersonal violence, unsatisfying public resources, domestic, conjugal, and mothering things to do. Instrumental endurance is not an alternative category intending to replace the categories used by professionals. In my view, it invites us to reconceptualize the harms done to women through their very own efforts, which are conceded in response to interpersonal, institutional, and structural constraints, and not as learned reactions, acute paralysis, or chronic incapacitated protection. These responses to violence can be defined as a form of domestic experience more than as traumatic, which is something that I tried to do in my PhD, but I don't really have the time to talk about it today. But domestic means that these women progressively domesticated and anticipated various threats, acquired knowledge about their partner's violence, and developed a domestic organization within a known site of life and action. And what I would like to highlight and question with this piece is also our need for biological evidence of innocence, which is the result of cultures of disbelief and blame as well. Biological evidence, in what I showed at the beginning of the talk, is used to prove evidence in the absence of verbal or physical opposition. But these uses of biological evidence do not support discourses about even when women do not actively resist, and even when they use their sexualized bodies to create some form of agency, they could also be innocent of all complicity in what happened. Even if biology here within the PTSD model is turned to as an ally, there also is a need to not just support victims by turning to biological evidence of their innocence. I thank you very much for your attention and I welcome the discussion.
Thank you, Adeline, so much for what was such a nuanced and important discussion and felt so very rooted in the lives of the women that you had followed during your research, and really so clearly conveyed. Thank you. If people have questions that they would like to ask Adeline, please just a reminder, if you use the Q&A box for those. I have some questions that I would like to ask, and I will start with those just while I'm waiting for people to submit the questions that they would like to ask through to you. So I wonder if we could think a little bit about the conceptual framing, Adeline, and how adopting the concept of instrumental endurance might change the way that frontline practitioners interpret survivors' behaviours that are currently understood through other frameworks. What might this mean for frontline services?
I think using that concept can enable to talk about all of the constraints which affect women that they work with, highlight the institutional and the structural elements which shape their lives, and not just talk about the acts of violence. I think it's also a means to support the agency and that these women actually deploy within their relationships.
Thank you. And I wonder if you could think about the examples that you gave where saying no could escalate harm, and the example that you gave of the GP, kind of that being the advice that they were giving um to their patient. Whether you want to could say a little bit more about, how healthcare professionals um can engage with these findings, and perhaps change the ways in which they're interacting
I
with
think
their.
one of the difficulties for healthcare professionals is to try to support patients, challenge their, victim blaming theories and all of that. But sometimes trying to do that can also lead to responsibilizing clients for their own situations. In that case, there is like this GP is trying to come up with a solution with something that will could end violence, even though like I'm not sure the science would support that. But I think there is a balance between challenging guilt, challenging blame, and also reproducing some form of responsibilization of individual clients, which is a dilemma that I've also heard a lot when I talk to healthcare professionals, when I presented those materials to them as well.
Thank you. A question from one of our attendees. I wonder if you consider what victims do in their minds a form of resistance, thinking of something else, articulating objections in mental thoughts, etc. I call this mental resistance. There are forms of emotional and spiritual resistance to push back on feelings of shame and objectifications, which can be considered resistance. What do you think?
Yeah, I would agree with that. These examples and this analysis, what I described is practices which are some form of acts, but which you can see, But I think mental acts are also a form of surviving. Practices such as trying to think about something else, think about in this the current project I'm working on. I'm hearing about thinking about the TV, looking at something else during the violence is happening as a form of resisting, even if it's even less noticeable than what I described. So yeah, I would agree.
And a second question, what has been described will be familiar to most survivors of abusive relationships. In the context of the physical and mental abuse, how much of a priority is the sexual violence for these victims?
Um, I think the priority, I think sexual violence is not the priority for the women I worked with. For those who were mothers, their children were their priority, and everything was hierarchized after that. Physical violence and physical brutality often was used also as a reference point. So sexual violence was either weighed against the reference point of physical abuse or their children's well-being and awareness of what was happening. And the other thing I would say, which were their priority, was for those who are trying to leave, all of the bureaucratic thing they were forced to have to comply with, which was really stressful. So I would say those were their priorities.
Thank you. Um, did you, in your research, did you find there were challenges for the victims where their support systems and professionals might advise them not to engage in sexual gratification, as it could send the wrong message to their partner?
Um, I I think the example that I gave with the GP was some form of an ideal typical advice that was given. There was somewhat of an ambivalence in that setting because every patient that the practitioners, for instance, would see and who would say, for instance, disclose fearing their partner, having some form of description of their situation, which would classify them as a victim of domestic abuse, was immediately defined also as a victim of sexual violence, even though there is also some research that shows that it's a little bit more complicated than that. But there was a reduction, the logic was that. And from that point on, they were also doing things like writing prescriptions against sexual violence. So there were different sets of practices around the treatment of sexual violence within domestic abuse. But what I'm hearing with the example you gave, I don't know, I'm hearing some form of a responsibilization and blame of victim. I did not really witness those kinds of statements.
Mhm. Okay, thank you. As to how intersecting factors such as economic precarity, racism, parenting responsibilities shape the forms of instrumental endurance described, and perhaps what that implies for service responses.
I think the practices that I'm describing are forms of handling it myself, doing it myself, which are completely tied to distrust that these women were having towards practitioners because most of them were white, the practitioners they met. And we've had numerous conversations about the different forms of bureaucratic care related and police racism that they or their children had suffered. So there was definitely a form of distrust caused by racism. And in terms of class, I think one of the problem was that with no concrete material support, they felt trapped. So even like in the area I was researching, it took between 3 to 4 years to benefit from social housing. So there was a real sense of material entrapment that added to distrust created by racism caused by practitioners.
Thank you. And you talked about how some women's actions were shaped by the need and desire to protect children. How do you think services should better account for these relational and caregiving considerations?
Can you repeat the question, please?
Yeah, so you talked about how some women's actions were shaped by the desire to protect children, and I wondered if how you think services should better account for these kind of caregiving considerations in their work with women.
I think mothering is really complex. What I documented in the field in my fieldwork was that often patients who are mothers were treated mostly as legal guardian, as people with with legal responsibilities. So the law came into the equation really rapidly. And so, for instance, if a woman was describing domestic abuse, they would write in France, it's called a signalement that would, that was mandatory to protect the child. So there was a jumping from the mother to the child. And in the process, all of the mothering projects and the lived experiences of what she wanted to do as a mother was deprioritized behind the legal requirements and the legal guardian. So mothering is really complex. They try to reconcile that with trying to support mothers' skills, love, trying to not undermine their own mothering practices, but in de facto that was what was being done. So yeah, it's a balance.
And it sounds from as you're talking about the gaps in housing and welfare and legal protection really play a role in shaping the kinds of institutional endurance that you describe. Would you say that's the case?
Yes, yes. I think what I was trying to, I didn't really have the time to talk about all of the institutional and structural context for those practices, but these practices, I think, are shaped by everything that's unattainable in terms of collective resources, structural resources, material resources.
I've just noticed a question in the chat as well as in the Q&A. We come across incidents of coercion in our services, and this is from a attendee who works in an abortion service. This raises the additional question of whether there is sexual violence in the background, and it would be useful to hear your views here.
I'm really not an expert on that question, so I can't, I'm not sure I can answer that without, just giving my opinion. So I'd prefer not answer to that question, if that's okay.
That's fine, thank you. Um, do the women identify their actions as resistance, as this contradicts the social attribution of passivity of victims?
So the data that I described were not shared with me as forms of resistance from the perspective of my participants. It is me who, upon analyzing them, actually realized that there are forms of resistance. The way it was described was way more, a mundane description of everything that they have to do. So to me, it's a form of constrained agency. It's a form of socially and materially structured form of agency within constraints, but in the way we were exchanging and the way I, heard about those practices, it was, one detail within a longer story about something else. Like really, I really had to track all of those examples within my data, so they were really lost in the middle of other things that they wanted to talk about. So no, they would. I'm not sure they would uh, identify them as explicit resistance. Some of them, yes, like the example of the gene was explained, but not all of them.
Do you think that recognizing these forms of agency and resistance could and should change the way professionals communicate with survivors about their choices and their experiences?
I think I think the overemphasis on neurological and hormonal processes hides what I've been trying to show. So I think there is a need to also, document other sources of constraints, but also other forms of other practices that women do on a day-to-day basis. So I think if practitioners maybe adopted a broader understanding of the topic of resistance and constraints, that would maybe document and enable to have other conversations with clients.
Thank you. And just one last question before we close. We've talked a lot about kind of service implications, but in thinking about future research, how would you see these findings as shaping future research priorities? For example, developing new models of recovery or resistance beyond trauma, or there may be, I'm sure you have lots of other directions that you want to take this work in, and I'm interested to know about them.
I think definitely trauma and recovery. I think also maybe like that's really not my expertise, but I think all of the reflections around consent, how the law interacts with consent. This also has implication on those debates, and on ways like all of the theories of surviving violence, agency, we're thinking resistance. Yeah.
Thank you. It's been so lovely to have you here, Adeline, speaking with us. Fascinating research and so important to hear the women's voices and experiences and your analyses of them. So thank you for being here with us today. As I mentioned, we will be sharing the recording and a copy of Adeline's slides and some other resources that she has linked to us. So please look out for those appearing in your inboxes over the coming days. We will also be having a webinar in April. We will share details of the date for that and the speaker information and sign up link. So if you have enjoyed today's talk, please do check back for our future events. We will leave it there. We are right on time. It's been a wonderful 45 minutes with our speaker, with you all, and we look forward to staying in touch with you all and to hopefully seeing you at one of our future events. Thank you again.
Thank you very much.